I'm asking.
No,
I think
probably fifth or sixth, probably.
no. According to me, it is. I think eighth or something.
Okay. Okay, so we'll go live in 5, 4, 3, 2, 1. So, good evening and welcome everybody to this 8th edition of Wednesday Musings with Dr. Borate sir. And today we have a very interesting topic on CMEs in orthopedics. And so we have seen a drastic change in last 1.5 years on how orthopedic surgeons are getting educated both online and offline. So we'll discuss about this issue and how the accreditation and other things work. For further proceedings, I'll invite our convener, Dr. Tarang Khairnar. Over to you, Tarang.
Thank you, sir. Thank you for having me here. Thank you, Borate, sir. So, when we decided to do this talk, I was just wondering about an episode I just came across. So, there was this prisoner who was released after 68 years in America, I suppose. I don't remember actually. But then what he saw when he came out of the prison, he couldn't believe, and he thought it was in his wildest dreams that he would believe such updated cars and such modernized infrastructure. So I was just wondering, if this prisoner was given continuous education on how his city is progressing, probably he wouldn't have been that surprised. So similarly, in our medical field also, we are upgrading on at such a pace that having continuous medical education is a must. Obviously, is a necessity by the institutions as well and the MCI as well, as it's an learning is an ever changing, everlasting process. And in spite of being in a medical field, and CMEs help us to remain competent and aware about the new and developing areas in our respective fields. So, Borate sir, how did this CME, the need for CME started? How are we coping with it in the present day? How were the CMEs being conducted in your earlier days? Over to you, Borate sir.
Yeah, I think we didn't have any thing like CMEs. What we had were our annual conferences and the clinical meetings we had. So we would have, like in Bombay, we would have about 6 clinical meetings in a year, and they were rotating around hospitals. And everybody was welcome for these meetings, and they were conducted by the Orthopaedic Society. Other than this, we used to have the state and this annual conferences. Continuing medical education was only a concept then for trainees, So the Bombay Orthopaedic Society used to have a 3-year training course every year for the students who were undergoing training. And we used to have workshops only when some new equipment or some new type of fixation devices were being marketed. And as a part of that, there would be some training. I see the increase in CMEs only in the, last 15, 20 years gradually, because the technology is changing fast and companies are in competition trying to market new designs and new equipment, and therefore they are encouraging and motivating more and more CMEs. Hello.
Yes, sir. All right. So what is the need of a CME in today's era, if you see in the last 2-3 decades?
So see, one thing is that
Yes, sir. Please go ahead.
One thing is that, even from long time, we have known that learning is a lifelong process, and learning never stops. Um, but the constant upgradation of learning has become more necessary in recent years, because there is a huge and a very rapid increase in available knowledge and increase in technology and technological advances. Now, in the old days, for a concept or a certain type of treatment to change, it would be a long time, because books were like new editions were published. When a new edition came out of a book, the knowledge in that book was already 3 or 4 years old. And till the new edition of that book came, one didn't really get a, you know, concise mm, um, knowledge of what has changed in the last 4 or 5 years. But now, because the concepts are changing very rapidly, and it is necessary for the orthopedic surgeons to know what is changing, how much is changing, and how much of it is now necessary to become part of what are known as clinical practice guidelines and best practices. So, almost all large hospitals in the medical colleges as well as in the private field, they are now required by law to have practice guidelines. And those practice guidelines will be the guiding mm, kind of Bible for them when they treat patients. And whenever there is any dispute about what treatment was given, whether the right treatment was given, the doctor would have to know the practice guidelines. And these practice guidelines are now being reviewed and revised and updated more frequently than what they were done before. So that's why, in order to update these guidelines, it is necessary to attend and keep abreast with the knowledge, and then decide which of these things need to be, adapted or, included in the current guidelines. That is the reason why CMEs are becoming so important in the recent times.
Absolutely. So, what is the mandate now to conduct a CME, or what is the mandate that a particular practitioner has gained sufficient upgradation of his knowledge through CME? How many CMEs should a practitioner should attend?
Yeah, see, this
Something
is
like
a
that.
this is a very important question, and unfortunately, we in India are much more behind the Western world, particularly United States, in the conduct of these uh, updates and knowledge update requirements. See, at one time it was believed that when a doctor attended his training, got his degree, and got his license to practice, he had to renew his license every 5 or 10 years. But it was just a process of applying and getting it renewed. There was no real need to demonstrate that you have kept in touch with your subject. Now, in India, we are presently at the stage where the medical licensing is done by the state medical councils. And the state medical council requires every practitioner to renew his license every 5 years. And in Maharashtra, for example, they require you to have 6 CME credit points for every year and a total of 30 credit points over 5 years to make you eligible for renewing your license. Now, similar requirement exists in most of the state associations in India. But unfortunately, the amount of clinical meetings and CMEs that are available and are conducted are very um, different in different parts of the country. And so, in many other states, this requirement of credit points is not really implemented or enforced as effectively as it is in some states like Maharashtra, for example. And by the way, there is no special requirement for specialists. Like orthopedic surgeons are not required to have only credits of orthopedic training programs. They can have any credits as per the current rules. Okay. Now, this is something that has much more advanced in the Western world. For example, the thing is that in America, the renewal of your accreditation is a process which is done with your the board that certified you. And in America, the board is one for the whole country. Now, in India, the problem is we have got degrees from universities. Like I may have got it from Bombay University. Somebody else may have got it from some other universities. So there is no uniform all India body which is responsible for certification of individual specialities and renewal of that certification. This is a problem that we will have to fix sometime, because the state medical councils are basically concerned more with the general practitioners, and although they are currently having registers of specialists, it will be very difficult for them to actually uh, run programs for deciding what kind of CMEs will be required for orthopedic surgeons and so on. So these are very gray areas at the moment. So we are just happy that we are having a lot of CMEs. Fortunately, because of the pandemic, suddenly, it has become apparent to many of the people in the teaching and in the associations that the potential to hold virtual training programs is enormous, and they have exploited it in the last 1 year so much, last 2 years, that previously, we used to have like conference once in a year, and everybody used to look forward to it, and it used to be a huge event, and all that. Now you can have, or you're having like training programs every week or even every day. So if you look at the amount of material that has been put online and made available for training in the last 2 years, it is so much in volume that now the availability of how to get education or continuing education is not a problem for the average orthopedic surgeon anymore. But there is still one lacuna, because in the in America, for example, they have a requirement that certain number of your credit points have to be from self-assessment. So they have online self-assessment programs which are available, which you can take either free if you are an associate member or at a concession rate mechanism, or you pay for it and take the test. And before you take the test, you can have a pre-test reading what you have to prepare. You can find out, and after you take the test, you will get your result. And the thing is that you show that you have passed in that, and 20% of your credit points have to come from that. So if you pass a self-assessment test, maybe that test carries say 2 points or 3 points. So if you complete those points, then only you will get renewal of license. Now, all these are mechanisms which are in the interest of society at large and patients at large, who will now have the satisfaction of knowing that the doctors are treating them are going through a process of continuous education, and therefore their skill and competence is being adequately addressed by the organizations and bodies They are controlling the education of doctors. But in India, we are still not very um, advanced, but at least we have started, and that is a good thing, I would say.
Right, sir. So the differences between the online CMEs and face-to-face CMEs, we will come back to later. Come to that later. We'll also have a word with Ashok Shyam sir later. But before going to that, how are these points credited? How many, like you mentioned, 6 points
Yeah,
per
so
year at 30 points?
so in India, for example, to get 6 points a year, all you need to attend is 2 conferences, because most of the conferences which are of the state or national level usually carry 3 or 4 points. They're usually 2 or 3 day events, and they carry 3 or 4 points. So if you register and attend 2 conferences, you will accumulate those 6 points. And I mean, today, we don't have a real check on how much of the conference or how many sessions are actually attended by the delegate. But still, it is better than not having anything. The other thing is, if you are a postgraduate teacher, you will get 4 hours of credit every year if you can produce a letter of appointment and continued appointment of your education institute. So these are some of the ways in which you credits are obtained in India. Now, in America, for example, just for comparison, all specialists need accreditation renewal. This is done by the American Board of Orthopaedics. So there, in 3 years, you had to accumulate 120 CME credits, and out of part of them have to be self-assessment credits, and those have to be at least 20 out of this 120 should be self-assessment exam credits. So obviously, because these are all needed, these type of exams are now being conducted by associations themselves, by private players, educational institutions. So this has become a big activity now in the United States. Now, at the end of 6 years, you are required to accumulate another 120 points. So you're looking at like almost 20 points a year and taking at least one test every year. And they have something which we are not even considering at the moment. At the end of 10 years, you have to appear for a recertification exam. Now, that recertification exam may not be like the exam that you gave when you first passed the board. It might be a little different, but or similar. But there is also another requirement, that is to give evidence of performance in practice activity. That means they ask you to submit a list of whatever operations you have done in the last 10 years. And they try to make sure that you are not only uh, scholastically adequate, but you are also having adequate experience. And they have some special rules, like all CMEs must be in orthopedics or orthopedic subspecialties. And they have 2 accreditation bodies in America. One is called the Accreditation Council for Graduate Medical Education, and the other is American Board of Orthopedic Studies. So these are independent boards and bodies which do these things. Now, the equivalent we don't have in India, because the Medical Council of India is a general body which is responsible for all specialties and all undergraduate studies. And the Accreditation Council is substituted here by the state medical councils, which again are general bodies. So we have not yet reached the level of, specialized boards making sure that all their postgraduates are not only adequately trained, but they are also recertified in a very proper manner. This is a big change that needs to be done. What the good part is that in the pandemic and the post-pandemic era, we have now, even in India and any country in the world, we have a large amount of online and virtual learning opportunities. And there are now tools available for self-assessment. Unfortunately, they are mostly for USA and UK examinations and certifications. We don't have enough of material available for Indian scenario because there is no requirement yet from the bodies. Once the medical council and the state medical council start requirement of self-assessment, then these will become available and will be tailored to our own requirement. And we are seeing these webinars being conducted every day by anybody and everybody. So there are some advantages because these webinars are usually free and they're available, they're affordable, and even the expenditure for conducting webinars is less because people are, even the people who are delivering the program are remotely uh, uh, being made available. Um, there is a additional facility that these webinars can be recorded and you can play them whenever you want to, and you can attend them whenever you want to. During the program itself, you can simultaneously have interaction of multiple delegates from multiple locations around the world if you have proper software and proper interfacing. And this has made the quality and the potential for these webinars very, very good. Some of the problems are that, these are like, you don't have like a real face-to-face interaction. And many institutions may not have the infrastructure for conducting these events or even attending these events. And there is no control of quality. You just have to hope that whoever is conducting is taking care of the quality. And I still don't see self-assessments being part of these webinars to the extent that one would like.
Right, sir. So, having mentioned about the Western system of the mandate of credit points.
Yeah.
So, having mentioned about the Western system to mandate the credit points, that looks like a very tedious and very strict protocol to be followed there. And
Yes.
like you mentioned, it is not that stringent and strict in India. So why do you think it is not so strict and stringent in India? What are the problems one faces in India? And like you mentioned, like there are so many universities at the state level, at the national level, where a number of orthopedic surgeons pass from different universities. So there is not one body which is governing. So that reminds us that we have private colleges also and we have government colleges also. So what is the difference between imparting continuous education in these both, and what problems do we face because of this, sir?
This is what you raised is a very important question. And although we have two types of courses, one is the MS Ortho and the other is DNB Ortho. The MS Ortho is a 3-year course, and so is the DNB Ortho. But the DNB Ortho is mostly you study in private hospitals, whereas for the MS Ortho you study mostly in the government colleges or private colleges. But in both the situations, you write a thesis and appear for an exam. Now, the problem in India is very peculiar. You see, in the government colleges, the training is very poor because the trainees are expected to take care of the patients and the teachers are available for a short time. So the amount of time spent by by the trainees in treating and taking care of patients is so large that they have relatively less time to actually learn and actually be, getting knowledge and discussing whatever they have learned and having interactions with their teachers or mentors. And the other problem is that in the government colleges, the concept of subspecialties is not very well advanced. So the student comes out with a kind of, uh, uh, I would say, lopsided exposure to various subspecialties of orthopedics. And there is very, uh, not so good teaching learning happening. Now, the problem in private colleges is different. The problem is they don't have enough material in terms of patients, and they do have subspecialists or surgeons who are mainly specialists or subspecialists in something. So they may spend 3 years working with somebody who is only doing adult reconstructive, for example, mostly. So they end up becoming exposed to another lopsided way to orthopedics. So for various reasons in both the private colleges as well as the government colleges and the private hospitals, the product that we are getting or what we are creating is a generation of orthopedic surgeons who don't have a adequate general orthopedic background, and in most places the education is poorly organized. So they the people that come out of these institutions have these problems, that they're not organized, they're not taught how to organize their thinking and so on. And the exposure that they have to patients also is very varying, and the amount of mm, overall knowledge that they have is very sketchy. Now they do have to face exams and they do have to get through exams, and you see that confusion and you see that lack of uh, you know systems and lack of comprehensive training when we see the students. This is a big problem in India, and we need to actually uh, have a structured curriculum for all colleges, all states, all over India. We should have a specific guidelines how this has to be taught. I mean, how much time should a student spend in learning what? And this framework must be laid down for 3 years. And foundation courses are needed, which are not being done anywhere or very, very rarely done. There is no periodic assessment of competence. We are assessing knowledge in some places, but assessment of competence is something that is not being done. And we don't have in India, unfortunately, any psychomotor skill laboratories. We don't have cadaveric labs, and we don't even have uh, what is happening more today is, bone models and, bone workshops for trauma and learning how to do procedures. So all these things are lacking in our training system. And I think that there is a huge role for the Indian Orthopaedic Association. They should start a orthopedic residency committee, and they have to advocate with the medical council, the DNB, the central government and state governments, and they have to make them understand that if you look at the medical colleges and private hospitals and DNB hospitals, and you create a collaborative system where students who are studying in private colleges can or should be posted for 1 year in private hospitals to learn some specialized thing like, say, joint replacement or adult reconstruction, which they do not get enough learning where they are studying. And all this can be worked out so that every student coming out of every institution will come with a minimum and a required competence. This, according to me, requires a revolutionary thinking from not only the medical council but also the governments in the states and center. But unless we start this dialogue, nothing is going to happen.
So as
And
you were,
yeah.
So as you were speaking about the differences between a government and the private, this thing, and the students have to face the pros and cons of each institute. I just a thought crossed my mind. How about a student exchange program between a government and a private medical institute in the same city, probably, if not an outside city, if
Yeah,
not another
see,
city.
the problem with all this is that the facilitation should come from the regulatory bodies first. The regulatory bodies have to be made aware that, you see, because for example, Medical Council of India may be under the impression that all government colleges are centers of excellence and they don't see any need for anything to be done. Or, there are various problems with central government thinking, problem with state government thinking. So somebody who is a stakeholder like the Orthopedic Association, who knows the reality, they should advocate and tell them. For example, today, I mean, the problem is that postgraduate trainees are used as substitutes for consultants in the hospitals. They are just working for 3 years and learning whatever they can in whatever manner they can. There is no organized training program in most places. So this is something that needs to change. But in order to change, somebody has to point it out to the bodies like MCI and the DNB or whatever it is, and the state governments. And what you're saying is correct. It's like exchange, but it is a process in which every hospital or every college will have to introspect and decide what they would like to their students to learn more than what they're learning here, or what needs to be added to whatever they're learning. And so it is with the private hospitals. So this kind of interchange and interaction will be required. And suppose, for example, as a result of this, it is felt by the medical council that, and they agree, for example, to make the MS orthopedic course instead of 3 years, 4 years. And either in the third or the fourth year, the student has the option to do an elective for 1 year outside the hospital or the college where he is affiliated. Then automatically these things will start happening. So that is what needs to be, started. But to start it, who will bell the cat? That is the problem.
I think, sir, also that it has to come with the acceptance. It will start with the acceptance that a private or a government institute lacks something. They lack something. Then to fulfill that, they have to send their student in exchange with the other students. Only then it will take some initial steps. It will work out. Unless
But
they
look,
don't accept that there is something lacking in their not really teaching, but their protocol, it won't start the ball rolling. Like
see,
it has been said, who dares to teach must never cease to learn. So even
no,
the
but
senior, yes, yes, sir, please go ahead.
see, I like to be little, I have a little different view. I do not sincerely believe that any medical college or any private hospital or a private medical college will come out and say that they are deficient or lacking. By definition, they will not say it. They cannot say it. However, if the government, who can tell the government? Who can tell the regulators? The professional bodies are by definition not, they are outsiders. They are what one would call objective observers of the system. Because the professional bodies, the members are teachers themselves of these bodies, and they are products of the education system. So they have a very good you know, uh, ability and to comment and to advocate, because they will be taken seriously, because when they say something, they are saying that this is the collective wisdom. And now if there is an orthopedic residency committee, that committee can also do surveys and questionnaires of existing colleges to find out, and then prove with the papers based on that, that in the government medical colleges, these are the things that need to be improved, without going into any specific college or without making any specific accusations. And in the private medical system, what are the lacunae? And with these, armed with these findings of these research papers, then they can advocate. And as I said, instead of tampering with the existing 3-year program, if there is just one simple change made, that the program is increased by 1 year, and an option of an elective for 1 year is made available to all the students. So it doesn't really reflect on the institution and doesn't require the institution to anything, but it gives the student the opportunity to experience. Like somebody who's in a private medical college, if he applies and is made given an elective in a government medical college, his requirement that he wanted to work in a government medical college is fulfilled. And so also for the government medical college students who feels that, he needs to be in a center of excellence where there's a lot of reconstructive surgeries going on every day. So once you create a change in the way the program is conducted, without in any way questioning the, competence of the system or the colleges, it is a much easier way of bringing about change.
Yeah,
Because
true.
believe
I
me, this
agree.
change is not easy. And unfortunately, our professional bodies think that this is none of their business. But we have to understand that they are the only one who can think about such changes.
Yeah. So I agree. Instead of saying we lack in so and so, that is why we are taking this step, rather than say just it is for the betterment for the students, we are taking this step. So one question which arises, if suppose this thing which you mentioned, the change which you mentioned of adding a fourth year and allowing the student to go outside the parent institute and go for an elective posting of a year,
Yes.
do you prescribe that the student choose the field, or does the body decides based on what his previous training for the last 3 years has been? The body decides his fourth year training should be which field it should be.
See, the thing is, these are mechanisms that will have to evolve uh, through a process of, again, surveys of the faculty, surveys of all the stakeholders to find out what is the best way in which this can be worked out. One would have to appoint committees of, representatives from private colleges, from government colleges, from DNB hospitals, and they will have to put their heads together, and there must be feedback based questionnaires with the students also, and by that a mechanism will emerge which meets the requirements the best. Of course, that will also have to be reviewed, and it will have to be uh, updated and revised based on the experience of the first 2 or 3 years. So one thing is clear, that some change is needed. Now, once you add 1 year, how to use it can be a process. And I think that it cannot be just by a simple debate here. I may have some views, you may have some views, but we will have to look at the system and look at all the stakeholders and find out what will work and what will not be questioned and what will not be termed as unfair and um, wrong and all that. So maybe some suggestion might be that for the electives, there will have to be an exam. And suppose the person who has opted for an elective in some subspecialty will have to show his competence. I don't know how uh, this will be done. I mean, it's not uh, easy to answer because in the United States, most of the hospitals, most of the medical colleges already have a matured subspecialty programs. So it is
Yes,
possible.
I was about to ask you that. And do we lack perspective when it comes to continuous medical education? I was about on what do we lack as per the USA or rather any Western world, and as far as India is concerned. So
See,
please go ahead.
we are still very, very behind the USA in terms of development and maturity of subspecialties. So basically, we are neither providing comprehensive and all-round education to the orthopedic general surgeon properly in either the private colleges or in the government. Both the places have some deficiencies, as I pointed out. So, unfortunately, we are not producing good general orthopedic surgeons because of the problems we have. And we also do not have adequate programs for subspecialization. So, the students currently have forced to do fellowships and, do training without any certification in whatever hospitals or opportunities they get before they can uh, feel or adequately trained in that subspecialty. So right now we are in a very gray area, and so I'm not saying that the US system is perfect. It is also evolving, and one of the problems they have, which we are not even talking about here, is that the way that they examine the students and the way that they teach the students, they have now agreed and they have not realized that this system is outdated and it is no good. The system that I was trained in, the system in which you are trained in, is called the master and apprentice model, where somebody who is your teacher or mentor, you work as his assistant for 3 years or whatever period. And in that process, you learn from him whatever you are supposed to learn. Now, this system is inadequate and it was okay in the past, but it is not good enough today because today more and more surgeons are becoming subspecialists. So the surgical skills are becoming complex. The technical tools are becoming uh, quickly obsolescent, and new tools are coming. So all this is leading to a completely different requirement of skill acquisition. And we don't have any system of confirming or testing whether a student has learned and acquired a certain competence adequately. We are just testing his knowledge and we are hardly testing his actual competence and skill to do things. So they have realized this and they are trying to change their systems of how students are trained and how students are examined and how they are tested for uh, competence. Because in the old system, what it was you observed somebody doing an operation, then you assisted the surgeon, then under the guidance of the surgeon, you did part of the operation. Till at one point, the surgeon felt, okay, you can do the whole operation on your own. And that was the apprentice and master thing, where at some point, you got an opportunity to do the operation independently. Now, we have learned through experience and through research that if you want to learn to do an operation well and become good, the learning curve for most operations, which you are learning new, is that 30 to 50 cases you have. Now tell me, in our training programs, is it possible to do that many cases for a young trainee? It's not possible. And we are just talking of one procedure. So if you decide that by the time a student passes out, he should become adequate in independent operations of say 20 procedures, let's say. So 20 multiplied by 20 means he will have to do 400 independent operations or something like that in his second and third year, or probably only in his third year because he won't get chance in his first year. So the amount of independent work opportunities also do not exist to produce people who are competent and confident. So now with newer techniques coming out all the time, newer devices, even the established surgeons have to go through the fresh learning curves now uh, quite frequently. So for a new student, it becomes even more harder. That's why we have to give up our thinking of, because I learned that way. I learned by observing and then learning independently. So everybody whom I train must learn only by that way. That is the only correct way. Is something that we have to give up now. We have to change our mindset. And also, one some good part that has happened is that now we have virtual learning, we have simulated learning, which was not there 20 years back, and which is not there even today in most of our medical colleges and most of our hospitals. Let me be honest, because it costs money and it costs investment, and that investment has to be made by the teaching institutions. They have to invest in simulation learning. Even our conferences and our workshops in future, maybe 5 years from now, they will be like, a games arcade where when you go to the conference, you can spend 2 or 3 hours going into an arcade where you can sit and practice doing an operation. And you can get, even if you do it properly, and you'll get a certificate saying, okay, you did it properly or you did it adequately. So instead of watching and listening to people speak, you will have an entire game area or like an arcade area where you can learn new things and you can practice new things. So these are the things that we need to seriously look at. We must invest in them. We must make them better and better through research. And that is how we will produce good and competent surgeons for the future. And although we might be behind the United States, there is nothing to stop us from doing it faster. We don't have to take 20 years to come to the level of the other countries.
Yes.
We can, if we are determined and if we are in consensus, and if we propagate these ideas, then we could probably be there much quicker than what they have reached.
Right. So, like you said, we don't have a single governing body of orthopedicians. It is the MCI that decides. And like it has been debated that a sports person should always be a sports minister, a doctor should always be a health minister. So why not an
Yeah.
orthopedic body be responsible for mandating the rules in orthopedic practices? So it should be that way, and if that happens, we are not far behind. We are just about there. So now we are discussing about CMEs, about how the credit points are allotted, the differences between India and the Western world, and the differences between a government education system and a private education system. We also discussed at length about that. Now, a little bit controversial question, I would say. Your take, or how, what is the present scenario on the sponsored CMEs in today's world?
No, I mean, look, the whole problem with sponsorship is who is sponsoring it. There are two types of sponsors. One are the pharmaceutical companies, and the others are companies that are producing and marketing instruments, implants, and such like. So one has to see that whether there is a conflict of interest in the sponsor and what is being sponsored. So if a pharmaceutical company that is making medicines or drugs that are more widely used by orthopedic surgeons, and they are sponsoring a CME on something in which are not related to pharmaceuticals, and in which the promotion of their own pharmaceutical products is not the primary objective of the uh, program, then I don't think that it's such a unacceptable idea. But when there is a CME which is sponsored by somebody who is making a certain plant, and they are the manufacturers, and they are doing a CME to uh, explain what they are doing and how good it is to orthopedic surgeons, it is obviously not a there is a conflict of interest here, because they are not going to compare other devices, and they're not going to say, or they're not going to be realistic in the way they will depict their product, because they're obviously there to sell it. But unfortunately, today, in today's world, um, we don't have yet that realization of how we will um, regulate this conflict of interest, and how we will ensure that this conflict of interest doesn't adversely affect the acquisition of knowledge. We are still confused about it. I do not know. I do not have a clear answer. I can see that there is a conflict of interest, but I do not know how we should address it. We should address it. We must look at it. We must make sure that it is not um, part of. So we should have some programs every year which tell all the people who are attending what are the new things that have come, and what are their benefits, and what is their realistic role in the present scenario.
Right.
And if that is done adequately at a more respectable level, then at a smaller level, these kind of workshops, which are sponsored by somebody trying to sell something that they are making, will not be so, it will not impact the practice of orthopedics as much as it is happening now.
Right.
Because now the scenario is more riddled with sponsored programs where the objective is clearly to promote something. And there is the person or the senior orthopedic faculty who are supposed to be very, very aware of this and make sure that it is not unilaterally projected. Unfortunately, it's not working that well as we might think.
Yes. So I think on these lines, I think suppose on a drug level, on a pharmaceutical company level, if a drug or if a company has a patent for a certain molecule, and if they have come up with a certain new research, and then if they are sponsoring regarding it is still acceptable. And then if suppose there is a biomedical equipments company who is willing to sponsor, and at the same time they are also willing to sponsor the simulation models or the sawbone models, I think it's a win-win situation for both the parties if something like this.
See, currently our approach is that we insist on disclosure. So if somebody comes to us and says, okay, I want to do this because of this, and the audience also knows that this is being done by this, and they want to attend it, then we don't mind, simply because it is not being done. It is out there in the open. The conflict of interest has been disclosed, and like that. Um, I I agree with you that we need sponsorship for education, sponsorship for training, And but it is our responsibility to see that the sponsorship doesn't come with with too much of promotion, like that. Like for example,
The main thing, the main learning point should not be overshadowed by the promotion itself, by only the
yeah, like
promotion.
for example, I was part of the Johnson Fellowship program. I was selected for as a fellow many years ago, and we traveled for 6 weeks around the country, and we visited all the teaching medical colleges in six large cities in India, and spent 5 days in each of the cities visiting the departments, presenting our work and seeing their work. The company had only put up the money for this whole program. The program was conducted by the Indian Orthopaedic Association. And when we came to Mumbai, because Johnson had their manufacturing facilities there, we had a half-day visit to the factory where they showed us what they do and how they manufacture and all that, and they gave us a lunch. So other than that, there was no other involvement of the sponsor in how the program is done, who is being trained, how they are selected. But everything was done by the association. Yeah.
Just a second, sir.
Yeah, I think the recording is stopped.
Yes. Sorry for the technical glitch. Our main host has
Gone off the radar.
Yeah, gone off the radar, is not accessible. Just a moment. Okay, I think we can continue. You were talking about.
See, one thing I wanted to talk about was that I really appreciate the American system where they believe in training of everybody for everything. They don't assume anything. So, for example, as an orthopedic surgeon, if you want to renew your certification, your training must be in, say, orthopedic related things. But other than that, you need to be trained in, say, medical coding. You need to be trained in how to keep patient records. You need to be trained in how to combat stress. You need to be trained in how to deal with your colleagues. You need to be trained in how to mm, be a team leader. Suppose you are appointed as examiner. You need to be trained on how to conduct examination. So they have certain requirements. So when you are appointed as an examiner, it will be conditioned to your having done so many, hours of training and completed a questionnaire-based evaluation of that before you will be appointed as examiner. You understand? So, हमारे यहाँ क्या है कि if you are a teacher and if you have completed 7 years as a teacher and you're eligible to be an examiner, you're just appointed as examiner. And nobody cares to find out whether you know anything about how it is done. It is assumed that because you are in a teaching institution which has exams every year, you will just through a process of seeing and observing become competent. But the American system doesn't uh, uh, stop there. They say no, there must be specific training. There must be information has to be learned. That is what they believe in everything. And we need to understand and start emulating them if we are to become better at whatever roles we are supposed to play. For example, tell me, how many of our orthopedic surgeons are trained on how to be an expert witness in medical legal cases and liability cases for insurance companies and all that? How are we trained how to depose in court when there is a case going on where we are only experts, where the policyholder is fighting with the insurance company because he's not been adequately compensated? So how many of us are trained in assessing disability, for example? So all these things are important, but they are not considered as credits for CME as orthopedic surgeons by the orthopedic board. But the hospital and the medical council of that state may require you to do many of these things. So we have to understand that being an orthopedic surgeon is not a unidimensional thing. And being a practicing doctor is not only related to your competence in orthopedics. You must be good at being an expert witness. You must be adequately trained in how to code, because if you're going to train your residents and if you're going to make sure that the whole process is going properly, you yourself should be trained in it. So there are so many aspects of training which are part of being uh, not only a competent orthopedic surgeon, but also a competent part of a team in a hospital or a member of society in various roles that you are expected to play. Unfortunately, we know about all this, but we don't have systems in place and we don't have mechanisms in place which are necessary. So everybody, for example, who is practicing trauma should undergo every year or 3 years a disability evaluation and give an exam to demonstrate competence that he knows about all that. And he should undergo retraining in expert witness and what are the various aspects. And if such programs are made available by either the medical associations or the orthopedic association online, which anybody who wants to can take them anytime for a payment of a fee, then we will be providing that platform. And providing that platform is very necessary before it will start getting used. Once we provide that, we cannot wait to somebody to tell us, no, let's pass a resolution, we must do this. We must make all these tools of learning available and for a certain consideration, because otherwise people don't value these things. And only if there is a consideration, then there is a interest for the person who is doing the work to do the work. And the consideration will also go in some way to improvement and updating and revision of whatever is being out there. You know, so there are so many aspects of orthopedic practice that require independent training and independent assessment. Once they are out there, now suppose once all this is out there, then the courts can say that anybody who's coming an expert witness, you will have to show this, demonstrate this. Or the medical association will then make it compulsory or make it mandatory. Right now, so we don't even have anything available in a regular basis 24/7, which is there available for anybody wanting to acquire that knowledge. Right.
Like I mentioned in the middle of our talk, who dares to teach must never cease to learn as well. no matter how senior you are or a faculty member you are, one should all be the new learning updates should be made compulsory to the senior practicing orthopedic surgeons as well. And then there are so many varied number of fields where one can get knowledge about.
Yes.
So all in all, that was by conducting these, by being the host of these Wednesday Musing, I can also say that I am also getting continuous medical education from Borate sir about so many other fields. Though I'm not getting credit points, but maybe in future OrthoTV might come up with credit points as well.
So
Yes.
I just Tarang, that's a great moderation and great session. I just had this uh, thing about credit points, and it has been an issue with me for a long time, especially for us in India.
Yeah.
So when we are looking at it in ethical sense, the point system does not include any assessment,
Yes.
and
True.
it is so when we hold a CME or a webinar which has credit points, a lot of people just register and just physically be present. I don't think there is any upgradation of knowledge for most of them.
Yes.
They are just there to fill the form and get the certificate because 6 points are necessary in the year.
Absolutely.
So is it helpful or is it not helpful? Or I mean, I don't see a lot of logic in doing this. What do you say, sir?
No, I quite agree with you that we must reform our program of credits to include a certain percentage of points that are subject to taking the self-assessment uh, in whatever subjects that you want. It need not be directly related to the CME itself, but if everybody who is planning and conducting the CME, if they are made to create a good assessment program, maybe break it up into 2 or 3 sections and require that for the person to get the full credit point, they must demonstrate their competence in at least one of the 3 sections by taking an assessment test and passing it. And if they are not able to do it, they are free to run through the program, the recorded program again, and pass that test. So that is one way of ensuring that our participants are not only listening, but they are also tested for whether they have gained something from that whole process. In the American system, as I said, every year you are required to accumulate 120 points, but out of that, 20 points have to be self-assessment, which you have to pass. So they are now having all these self-assessment tools which are made available to the participants in the CMEs as well. I'm not really sure how it works there and whether it is directly related to the CMEs itself. But I'm sure they are having all models and they're learning, and they'll revise and they'll keep upgrading the model of how much assessment should be a part of the continuing education. Right now, it is about 20% there. For us, it is zero. And as you pointed out, we don't even actually make sure that the guy is actually listening because we don't have any way of confirming that he's listening.
So like Tarang mentioned in the beginning, if inmate comes out after 20 years from the jail and he sees everything new,
Yeah.
he feels that if there was a system and he could have learned, it would have been better for him.
Yeah.
Don't we feel, I mean, like credit points are like enforcing something on us. Don't we as a community feel that there is a need for upgradation for ourselves? Or do we remain at the same level? Is if is that the reason why credit point system are implemented and enforced upon us? I mean, what is the
See, unfortunately, first of all, we live in a world that is now more and more requires us to be responsible for whatever we are as professionals. And it is being applied. See, this is how society is changing, unfortunately. Society is now requiring that everybody who is a professional, whether you are a truck driver, it's necessary that somebody checks whether your eyesight is good. So you might say that, somebody who has bad eyesight, he should not drive a truck, or whose eyesight is not good enough. But the way to ensure that nobody has any harm is to make sure that whoever drives a truck needs to prove that his eyesight is adequate at fixed intervals, and not only once when he is given the license. So these are mechanisms that society is adopting or incorporating into how society functions, ensure that the interests of society are served best by ensuring that whoever is serving society is competent, as well as we don't depend on him to,
so I'll say maybe competent on paper, and
yes,
but I mean you can have a paper to show that this is what it is. Whether it is really competent or not, it doesn't matter. It seems like that, isn't it? It's a half-heartedly implemented system.
yes, I see, but we have to also understand that the process of improvement of any social system is an ongoing process. And as long as we respect the rights of the individual, whether it is the provider of the service or the recipient of the service, both parties have to be constantly looking at this thing in a positive manner. For the professional to expect that or to believe that, look, and it's a very individual thing. Somebody might say, I know everything, I don't need to be tested. The other person might say that it's unfair that I'm being tested. So always, whenever something is enforced in society, I agree with you that it should be minimum and it should not be felt or perceived to be unfair. So this concept of fairness is very at the heart of any social quality improvement. And I would suggest that professionals have a big problem because because we learn more and we are uh, becoming skilled at what we are doing. We tend to be very more and more egoistic, and we are uh, more unwilling to be tested and judged. So it is a fact. But we must also understand that as a member of society, when we look at other professionals, when we look at other aspects of society, the same fairness that we expect from them, we should also understand that much uh, we should also accept in terms of being assessed. And I agree with you that self-regulation is better than mandatory regulation.
So based on the assessment, I would like to mention here, I had attended a workshop about for the plasty and scopy. And to be frank, that was a very thorough and a very comprehensive workshop. But again, not to mention that it was an FRCR affiliated workshop. That is why they had a thorough protocol of a questionnaire before the workshop and a little bit tougher questionnaire after the workshop. And then we had to compare ourselves on how much knowledge we have gained and how much. Uh, the basics of scopy and plasty, they are still with me. So if the agenda is to impart education and receive education on the attendee, the CME is a good idea. It's a win-win for both the situation. But like Ashok Shyam sir mentioned the concern that the CMEs are about the credit points more than the imparting.
Absolutely. I mean,
No, but
I mean, tell me if you both have not felt the same.
Yeah,
People
no,
attend
but
CMEs for credit points.
but
yeah,
let me put it to you, Ashok,
Yes, sir.
that if we are to improve, it should start at our professional bodies. So if the Indian Orthopaedic Association, for example, through a process of brainstorming decides that we will every year set a standard of requirements for a CME to be accredited by us. So as Tarang was saying, it should have a pre-test and a post-test, without which we will not accept it. And
No,
then,
forget Indian Orthopedic Association. Is there anybody in the country that is doing the same? Any
no,
medical body?
no,
There is
no.
no,
nobody in the
no,
even
but
more
see,
academic. There are yeah.
see, if I'm just saying Indian Orthopaedic Association because it is the professional body of orthopedics. So if they create a framework or a guideline and they start saying that what we approve are better than what others are doing, we'll approve only the good things. Then at one point, they can go to the medical council, state medical council, and say that start an accreditation program for orthopedic surgeons and make it mandatory for them to attend these programs because we are taking care that they have better quality and better standards and better way in which they are conducted. So it's up to us. If instead of the Indian Orthopedic Association, if there is some other body that you feel might do it better, fine. But if a
No, I'm
medical,
just saying that there is nobody who is doing this or was doing this even in the past because we are independent bodies. We can think about
no,
this
but
thing
these see
independent of credit point things.
these are the roles that we must look at if we are to gain back the respect and the stature that we expect from society. What does society say? That doctors must self-regulate themselves. Now we are always looking at playing like the intermediary when there is a dispute between a doctor and a patient. But why are we not focusing more on how to improve and how to create mechanisms which will ensure that we ourselves and our colleagues will have mechanisms to improve our knowledge, improve our competence ourselves. And see, if a medical college, for example, in some state, were to start doing this, it would not have the stature and the credibility that an association or organization which has an all India presence and an all India membership. That is more important than the now the. I agree that Indian Orthopaedic Association may not have any stature in the regulatory bodies, but to get there, you have to start doing something. If you say that, this is
No,
not
I
my job.
agree. There has to be a beginning, but the credit point system has been here since a decade now, more than that,
Yes.
and I
No,
think it
it
is a
is.
enough pilot period for us to understand the pros and cons of it and to make adjustments into it, which do
Okay,
not look, I mean, anywhere closer
okay,
to
I,
knowledge.
I put it to you that since you are such a, um, great at research, why don't we do research on the credit points and their implementation in states in India? Because what you think 10 years is adequate is based on your perception of Maharashtra. Maybe if we did research of all the states, because to my knowledge, in many states, there is no system yet. They are just renewing licenses on the basis of that person giving in writing that yes, I attended.
Exactly.
Yeah. So,
So here also there is a system, but we
yeah,
can get certificates without even attending.
yeah. But then I'm saying that at least in in the Maharashtra state, they require those certificates. Even if those certificates are bogus, they require them. But if you go to some other states, they don't have any certification. They're just renewing the licenses. So
Sure.
I'm just saying that unless we bring everybody up to a certain level, we cannot expect the apex bodies of the medical councils to go one step further.
No, that's why I took this opportunity to raise the issue so we can move ahead. Nothing against the credit point system. It is good. It has to be it has to be upgraded and implemented now in a better way since we have the infrastructure ready. So there it is.
Probably CME and credit points, these two terms should not go hand in hand. CME should be about imparting knowledge, and credit point should be about making your registration, renewing your registration. And unless you have genuinely received that knowledge and imparted that knowledge for a PG, postgraduate teacher, the credit point should not be attributed. So let's not take these two terms in the same breath, CME and credit.
Even I think the CME, the credit point can be deployed for certain period of time, say 10 years after you pass your postgraduate. And the method to do that is you go back for a week to your postgraduate institute and work there for a week in a year. And that gives you all the 6 credit points.
Yeah, wonderful. Yeah.
Yeah, that can be done. But I want to bring in one other point, before we end. See, one problem in our social system is we don't seem to understand that to implement anything, we need resources and we need manpower. And that can only come when we start charging and creating some revenue models for all these things. Because right now, if you look at the Maharashtra Medical Council, you go there, the number of people who are actually interested with doing the job is woefully inadequate. The number of experts, and we just tend to think that only doctors are experts. But does the Maharashtra Medical Council employ a statistician? Tell me, Ashok. Do you think that so it's required, no? Because if you want to make these things on a professional manner, you need skilled manpower, which is nothing to do with orthopedics. You need good, secretaries. You need good statisticians. You need people with research backgrounds who can do a very good job in a very short time and upgrade and make the program very effective. But do we have the resources to appoint these people? Is there a provision of that in the our registration fees? Because we are not thinking of this at all. We are, when it comes to paying anything to anybody, in our society, we still think that we should pay as less as possible and everything should take care of itself. And then we also want excellence at the same time.
Yeah, so I agree with you. It's a mixed bag problem. There are multiple reasons why the problem exists and why the solutions are inadequate. So it's not a single point cure or disease. So of course we look at all the aspects.
Yes.
We need a multidisciplinary approach and wonderful solutions also we discussed today. And I think we are done for today's
Yeah, I think so.
Or we need to keep it continuing.
Sure. So I just wanted to put in a disclaimer that whatever we are discussing here, we are not trying to point out errors and mistakes in planning or in certain things like credit point or we are discussing so that we can bring out something positive out of it, which may be helpful in future for people who are looking at these aspects of planning and decision making and implementing these guidelines into the medical system. Yeah.
Sure.
Absolutely.
I agree.
We'll continue with our continuing education system on next Wednesday then.